is a yes. I'm gonna have to come over this way. Let's see.
No feedback.
No feedback. Feedback that there's no feedback. Perfect. Cool. Okay. And so we're live. Hey, everybody.
Hi.
Thanks for being here tonight.
Good evening. Another Wednesday.
I hope everybody's got a stout in hand or a water is fine.
You have your green on. This is green.
Yes.
And I see you're green.
I'm head to toe green, actually. Yeah. I can't lift my leg up that high. But we're here tonight to talk about chronic pelvic pain or general pelvic pain. And so it's not all, this is Endometriosis Awareness Month, but it's not all endometriosis though.
It's not all endometriosis. Yes, and that's very true. Chronic pelvic pain is a multifactorial disorder, which means it's composed of many different factors. ACOG actually defines it as pain symptoms perceived to originate from the pelvic organ structures, typically lasting more than 6 months. So it's very different than acute pelvic pain, which usually is something due to inflammation, infection, injury, trauma, but that resolves over time with treatment and with repair. Chronic pain, pelvic pain is very different. It continues to persist. The prevalence is up to 26.6% by some studies. It disproportionately affects women. And many women with chronic pelvic pain also suffer from depression. And some studies, one study, about 33% of women met criteria for major depression. So again, it's a very multifactorial disorder. Central sensitization, is an important factor. So this is when pain itself leads to an overwhelming response. And so a woman with chronic pelvic pain may have an episode of pain that in others may not be bad, but she herself feels it a lot more because of the central sensitization. In this instance, neurons and nerves have become activated to overwhelming response to pain and increases your perception of pain. And so this also explains why women with chronic pelvic pain continue to have pain despite being treated effectively with medication or surgery. It also explains why women with chronic pelvic pain just persist to have pain. So pain needs to be treated with an interdisciplinary model. So this includes specialists from different fields to address all the contributing factors of pain. And just like you were saying earlier, it's not all just endometriosis. So, we should really think about organizing the causes of pain to help facilitate better treatment. And we should think about pain in different locations. With women, oftentimes a woman has pelvic pain and they say, go see your GYN. It's not all GYN. Your pelvis is not just made of your GYN organs. You have your organs, your visceral organs. So if you think about them and you're categorize it as gynecological organs, GI organs, urinary organs. So gynecological organs, okay, endometriosis, fibroids, adenomyosis, ovarian cysts. These are things that we've talked about in the past. GI organs, or your bowel, your gut, right? And so things like IBS or IBD, and irritable bowel syndrome, inflammatory bowel disease, Crohn's can cause pelvic pain. Urinary symptoms, your bladder, your ureters, things like chronic UTIs, kidney stones, they can all cause pelvic pain. And so addressing the actual cause of pain is extremely, extremely important to having adequate treatment. Another cause of pain, neuromuscular, neuromusculoskeletal, fibromyalgia, neuropathic pain, pelvic floor pain. We've talked about that. And then psychosocial, one thing we don't touch on often, history of abuse, depression, anxiety, substance abuse. All of these can actually be translated to pelvic pain and chronic pelvic pain.
So this whole thing feels like such a mess for me from the patient's lens in terms of figuring out where to go or what to do. I mean, it seems like it's a whole chicken and the egg situation because one thing might lend itself to another, And I have heard friends of mine say that when they've been told that it was something that is, I guess for lack of a better term, psychosomatic, then they hear it's all in my head and I'm not experiencing this, as opposed to the root cause is not necessarily coming from just that location where I feel the pain. The cause may come from a different source.
And, honestly, the cause may really be, pelvic in initial origin. However, there can be a component that is psychosomatic that exacerbates the pain that you are feeling that originated in your pelvis. So again, coming back to the fact that it's multifactorial, it's not just one, may just be one cause, but it may not be just one thing that's perpetuating the symptoms that a person has. And so looking at it and organizing pelvic pain from where it may occur, and understand it may occur from different places or originate for different places or have different factors that cause it. Having an all-encompassing approach will allow for all-encompassing treatment. And for example, a woman with endometriosis, she may have endometriosis. If you only treat the endometriosis with medication or surgery, you're not necessarily getting everything, and she may not feel better. So because she still has pelvic pain, myalgia from her musculoskeletal pain due to the fact that she had endometriosis, and those muscle fibers are spastic because of the endometriosis and the inflammation from the endometriosis. That has to be addressed. That can be addressed with pelvic floor physical therapy, trigger point injections. She may have that central sensitization that we talked about. So her neurons are overacting, and those nerve fibers are overfired, and causing her to feel pain even more at a heightened sense. So treating her with neuromodulators like gabapentin or something may help. And then she may have depression. And so that just exacerbates everything. So that has to be addressed. So you have to think about the treatment with all those layers needing to be addressed to really, really address, to really, really get at the root of the problem. And I think, the most important thing that a woman, when she goes to her GYN, because that's usually the first stop, to talk about pelvic pain, would be to have a complete discussion. Don't, for herself, not to just focus on the fact that I'm here at a GYN, I need to talk about my uterus and my ovaries. Talk about everything. Talk about your bowel habits. Talk about your urinary habits. Talk about your sex life. Talk about the fact that you're always nauseous, or you feel like you have sensitivities to food. All of those things really should be discussed during the visit, because it gives a better picture, a more complete picture that can be taken and worked with.
That's such a good point, and such a good thing for you specifically to tell people, because I feel oftentimes like it's just such a rush, and I pick up on that pace. And so I kind of skim over things that I think are insignificant, and I think that they're insignificant because of cultural norms. We're getting some good questions over on the Instagram feed, which is one, can OBGYN prescribe psychiatric drugs?
At the end of the day, we all have the same medical license. And so prescription is really dependent upon the comfort of the practitioner. But that being said, psychiatric medication is not the only way to treat psychiatric disorders, depression, anxiety, and such. There can be behavioral therapy, cognitive therapy. Studies also oftentimes show that cognitive therapy and medication therapy work well, just as efficacious as each other. And when they work together, when they're used together, work exceptionally well. So you don't have to just, medication is not the only option.
Okay. And now there's a couple things I want to go back to. One is sometimes we know that chronic pelvic pain or any kind of pelvic pain can impact your sexuality and your sex life. And so I just want to point listeners to the fact that we are going to be specifically talking about low libido coming up in the next few weeks. So stay tuned for that. And then the other was that you mentioned the number 26%. And I missed it. Is it 26% of women experience chronic pelvic pain?
Mm-hmm. Some studies show upwards of 26% of women experience chronic pelvic pain.
Holy cow. And we probably just figure we're women.
Yeah.
We're just doing 20 other things at the same time. So what pelvic pain? We've got some great questions coming in on Instagram. What about the pelvic? Would pelvic pressure still be considered pain and treated as such?
Pelvic pressure can be a component of pelvic pain. Yeah, pelvic pressure can be a component of chronic pelvic pain, acute pelvic pain also, but it can be a component.
Mm-hmm. And how would a patient be able to find group therapy for chronic pelvic pain?
You know, there are a lot of, one thing that I think COVID has done for us is really helped us learn how to reach out to one another in different ways. What we're doing right now here virtually. And there are many apps available to patients, women, men also, for behavioral therapy, for talk therapy. And I oftentimes recommend that to my patients to seek out, because it's also a bit easier because you don't have to be in a group setting, you know.
Mm-hmm. Mm-hmm. And this is a great question, considering this topic feels like such a holistic topic. Mm-hmm. The question is, are there holistic methods for treatment of chronic pelvic pain?
Acupuncture, mm-hmm. Yoga, mm-hmm. Meditation, you know, even with physical therapy, pelvic floor physical therapy, I talk about that a lot, but, you know, that also encompasses a lot of yoga stretches and moves for myofascial pain, and also dry needling, which is sort of like an acupuncture, is the easiest way to describe it, biofeedback. Mm-hmm. So there are many options, you know, especially when you have that central sensitization. Part of the role in therapy is to change your perception of pain, to change your perception of touch. You know, medications can help to do that, but definitely behavioral therapy, cognitive therapy, biofeedback would help to do that too.
Mm-hmm. Wow, that's great. So I'm so glad that we've got listeners coming in with questions. I want to encourage you, if there's a topic that you see, to send us in your questions that are advanced, or you're welcome to always send them in privately through direct message across any of the social platforms, so that we can address your question if you're not comfortable posting it publicly. But it sounds like my son, who's 4 years old, has taken a recent interest in the body. And so he really wants to know what everything is. So he's been looking through a lot of books lately of anatomy. And yeah. The pelvis really is, I'm just revisiting it. It's really this bowl full of stuff. There's so much in there.
Full of stuff. Yeah, that I've never thought about that way, but it is, you know, and
it's so like at the bottom holding everything.
At the bottom holds everything up. I talk about it oftentimes, how it is your main stabilizer. Yeah, because it, you know, of where it is and what the pelvic floor is. But yeah, it's a bowl full of stuff. And for women, it is not just your GYN organs. And I feel that we don't get complete therapy oftentimes because it's passed off to being a gynecological issue when it really isn't. And, you know, oftentimes there are diagnoses I've made for pelvic pain that had nothing to do with GYN, that were bowel related or urine related or musculoskeletal. And it's just because, as a provider of healthcare for women, I'm usually the first stop, and that's fine. And I have no problem with that. But I think we all, not just as patients, but also as providers, have to broaden our thought process on what can cause pelvic pain, and also the treatments for it. You know, we talk about the pelvic floor physical therapy, cognitive behavior, but sex therapists also. You know, for those who are sexually active, pain specialists too, to help really drive the thought process on how to use pain medications. Opioids are not the answer. You know, surgery is not always the answer when we're talking about a chronic disorder. And so we have to think outside the box, going back to trigger point injections, Botox, gabapentin, on top of other forms of therapy can help to really get better results.
Do you know of anything dietarily that would be, I mean, I guess it depends patient to patient, right? But is that an approach as well to be included in the whole gamut of things?
Patient to patient, exactly. But, you want to have a clean diet, a diet that's not as inflammatory. If you have food sensitivities, you think about it, you really go down the list of what you eat and start to mark some things off. Okay, I ate this and I feel this way. I ate this and I feel this way. I had dairy and I'm not feeling well. Or I had something that was had gluten in it and I'm not feeling well. That being that specific about your diet and thinking about it when you're having these pain syndromes is a good idea to really try to navigate to what the answer is.
So what I hear from this whole thing, and you just dropped a wealth of information on us, is just, again, it just keeps feeling like it comes back to patient advocacy, and that we don't have to live with pain if we fall in the category of people who are experiencing pain like this. This is not something that this is just how our life has to be from here on out. There are treatments available.
There are treatments. And, the first thing I say to a patient is I may not be able to cure your pain because, that may not be possible, but at least let us address it. At least let us try to reduce it. At least let us try to get to the cause of it. So at least you have an answer, not saying that you will always be able to find an answer, but at least let us try. And so that's when we, again, take ourselves outside of just the GYN world because we're women and think about all the other things that make us human beings and how all those other things may play a role in what we're feeling and what's happening to us.
Amen and amen. And we're beyond our 15 minutes. There's just so much to talk about. Thank you guys so much for joining us. We're looking forward to being back with you next week as we talk about, I just want to make sure I don't get it wrong. We're talking about pain with sex. So that directly comes on the heels of chronic pelvic pain. So if you experience pain with sex or want to know more about that, send us your questions in advance or join us right here on all the social media platforms next Wednesday night. And then following that, we're very excited to have a conversation about low libido.
Yes.
So thanks for tuning in.
Thanks.